Hi guys, good evening. Can you all see me? Can you all hear me? A quick feedback. Hi guys, good evening, good evening, good evening. Can you all see me? Can you all hear me? All right, thank you guys. Yeah, so today we'll be continuing on the intestine series. So I've changed the time a little bit because we're not able to suit our regular timing. So as decided, we spoke that we'll be talking about inflammatory bowel disease. Just not able to access the chat box on the YouTube. Just give me a second. Just give me a second. Just give me a second, guys. Alright, guys. Chalo. So let's start. Now, we'll be talking about the topic that is going to be your inflammatory bowel disease. Okay. So, mota mota itna hai that we are going to tell you about the two conditions which are going to be predominantly secondary to an inflammatory etiology. So hence it is called as inflammatory bowel disease. In the inflammatory bowel disease, we have two components that I would like to discuss. One will be your Crohn's disease, another one is going to be your ulcerative colitis. One it is going to be a Crohn's disease, another one it is going to be ulcerative colitis. Now, before we start with anything, very detailed discussion about it, just give you an objective. What is the basic difference between a Crohn's disease and ulcerative colitis? Okay? So when I say that we're going to talk about two important conditions, number one, it is going to be your Crohn's disease. Another one is going to be your ulcerative colitis. One, it is going to be a Crohn's disease. Another one is going to be ulcerative colitis. What is the basic difference when you look at these two conditions, right? So when you look at the bowel wall, now when we talk about the wall, the innermost layer, let's say this is the lumen of the bowel. So I'm just going to show you that this is one lumen of the bowel. This is one lumen of the bowel that you're looking at, right? Same way for ulcerative colitis also, I can depict that this is the lumen of the bowel. This is another lumen of the bowel that is present across, right? Now, when you look at from inside out, we all know that the innermost layer of the bowel wall that you're going to see is going to be your mucosa, right? So if I say this is going to be the innermost layer, which is going to be mucosa, and this mucosa will be running throughout. The innermost layer of the bowel wall is going to be mucosa. So this is going to be mucosa that you have, right? Next to mucosa, you have submucosa, then you have inner circular, outer longitudinal muscles. We have the same component. Ulcerative colitis को explain करने के लिए भी same analogy will take. Now this happens to be the innermost. This is going to be your innermost component. That is going to be a mucosal surface. ये आपका mucosa हो गया, ठीक है? Now under the mucosa, you have the submucosa. Just for the sake of understanding, if I have to just depict the next layer that you will see just under this is going to be your submucosa, right? The outermost layer that we have already spoken across here. This happens to be the circular, inner circular and the outer longitudinal muscles, but this is how the bowel's architecture would actually look like. This is how the bowel's architecture would actually look like. Now, why I'm being very precise is if you understand one basic concept, then you will understand all the clinical features, what are the clinical manifestations, how do they vary between the ulcerative colitis and Crohn's disease. I took a little bit of time to draw this bowel wall so that I can make two important points that I would like to emphasize. Number one, if you just look inside, the innermost layer is going to be your mucosa, which is present, the white one. Then you have your submucosa. Then you have your muscular layer. That is the inner circular and outer longitudinal muscles. And the outermost that you can say, it is going to be the serosa in the bowel wall. The outermost that you see, it is the serosa in your bowel wall. Now, what is interesting about Crohn's and the ulcerative colitis is, once the disease is going to start, let's say wherever the disease is going to start, in Crohn's disease, the disease will start from the mucosal layer. It will start from the mucosal layer. But the problem is, it will not get limited to mucosal layer. It will breach into submucosa. It will go into the serosa. It will also involve the muscular layer. In fact, it will involve the entire thickness of the bowel wall. Now, hence, it is going to be doing on this end also. Another problem is, in Crohn's disease, you will not have a continuous lesion. You will see such lesions occurring all across the bowel wall, but not in a continuous fashion. They'll not be occurring in a continuous fashion, and this is their characteristic hallmark, that all these lesions which are going to be formed, they are going to be in a skip lesion pattern. They will be in a skip lesion pattern. There is no continuity, there is no pattern of growth. You'll see randomly these components or these bowel wall involvement is present. Now, two important things that I would like to emphasize here. One, it starts from the mucosa, it becomes deeper and deeper and involves all the way to that of the submucosa, right? It goes all the way to that of the submucosa as well. So, in the Crohn's disease, you see the disease starts from the mucosa, it involves the entire thickness of the wall. So, I can say in Crohn's disease, the entire wall is involved. So, it is a transmural disease. This is going to be a transmural is wall, disease is involvement, right? It's a transmural disease. It's an inflammatory disorder. Now what happens is, if you look at these two components, okay? Now this is a disease that is started from the mucosa, it is involving the submucosa, going all the way to the serosa. So the serosa is breached now. In the same way, the serosa is going to be breached here as well. Now we all know that this disorder is basically an inflammatory disorder, right? So you will notice that there will be a lot of inflammation around this area as well. You will notice that there will be a lot of inflammation. You see, there will be a lot of inflammation that is going to be present around this area. So this is all the inflammatory component that is present, right? Here also it is going to be a lot of inflammatory component. Now because of inflammation, there will be a lot of edema that is going to occur inside and outside the bowel wall. The edema that is going to present inside the bowel wall will result in diarrhea. ठीक है, तो जो इन्फ्लेमेटरी एडिमा होगा, एडिमा थर्ड स्पेस लॉस होता है तो वॉल्यूम भरेगा, जिसकी वजह से आपको डायरिया होगा, वो तो ठीक है, ठीक है, but at the same time you see there is a lot of edematous fluid which is going to be present outside the bowel wall also. Now though bowel, see there are two adjacent bowel loops and there is an inflammatory fluid that is present, and that inflammatory fluid will result in development. It will cause, or it will result in development of a passage between these two ends of the bowel. ठीक है, इस passage को, the passage that is formed between these two ends because of the inflammatory response, this is what we call it as internal fistulas. So from there's a lot of fistulization that is going to occur because of this particular phenomena, and I'll just highlight this, that the inflammation that has occurred. So this is all the inflammation which has occurred and all that inflammatory fluid that is getting deposited inside. Inflammatory fluid inside the bowel wall will result in diarrhea. Inflammatory fluid outside the bowel wall will result in inflammatory response. There will be synechiae, and that synechiae will fuse together to form an internal fistula. There will be internal fistulization is going to occur. है ना? Clear है? ठीक है? यहाँ तक there is no rocket science. Until this point, there is no rocket science. So in Crohn's disease, you see there are multiple inflammatory lesions that are going to occur inside the bowel wall. They are not continuous, they are patchy, and because two adjacent bowel wall, when they are going to be inflamed, they will get adherent. There will be inflammation called synechiae, so there will be adherence, and that will result in internal fistulization also. Now what is interesting is these internal fistulas will be present at multiple locations. You can see there will be another internal fistula that you can see can be formed here. There will be another internal fistula that will be formed here. There will be another internal fistula that can be formed here. There will be another internal fistula that can be formed here. So eventually you will notice that there are a lot of internal fistulas that are going to be formed between the bowel loops, between the bowel wall loops. So this is a very extensive disease that is going to occur in your Crohn's disease. So there are communication. See, this communication, you can understand, it won't be limited only to the bowel wall. It can have fistula with the pleura, right? It can, to the peritoneum. It can have fistula directly to a wound also, right? So all these are going to be very tricky situations to treat us later on. तो इनको ट्रीट करने में बहुत डिफिकल्ट हो जाता है, क्योंकि ये जो इन्फ्लेमेटरी रिस्पॉन्स है ना, वो एक जगह पे लिमिटेड नहीं है. इट इज गोइंग टू इन्वॉल्व मल्टीपल कंपोनेंट्स, एंड इवेंचुअली यू विल सी that all these come under the umbrella of this inflammatory component. So ये पूरा inflammatory component से ही आता है. So hence you will see the entire bowel wall is going to be compromised. Now what is interesting is ये जितने भी lesions है, whatever lesions that are formed, all these lesions are inflammatory lesions. ठीक है? Now when these inflammatory lesions, any repeated inflammation or chronic inflammation will heal by fibrosis. Eventually you will notice that these are going to get fibrosed. Now because of fibrosis, what is going to happen? The bowel wall lumen is now going to get narrower. So eventually when it gets fibrosed, the luminal wall that is present will also get fibrosed. Now as the luminal wall is getting fibrosed, what will happen to the lumen? आपका जो lumen था अच्छा खासा, that lumen is now going to get narrower. So all this wall is going to get stricturous. तो ये पूरा structured हो गया. Now because the entire lumen is getting structured, you will now notice the true lumen which is present, it is going to be like this. This is going to be structured lumen. So this is how the true lumen would actually now be look like. This is the true lumen that is present all across here. You see, because of all this, what has happened? The lumen is becoming extremely narrow. Now, if you've understood this, no, यही पूरा game है आपके Crohn's disease का. This is the entire game of the Crohn's disease. ठीक? तो did you understand कि Crohn's disease में हुआ क्या? मैं फिर से आपको एक rapid succession में बता देता हूँ. I'll give you a quick recap of what happened in Crohn's disease. Crohn's disease में it's an inflammatory bowel disease. Inflammation हुआ. कहाँ हुआ? At multiple sites. ठीक है? In Crohn's disease, there is no fixed pattern of inflammation which is going to happen. It will occur as a skip pattern or skip lesion. There are multiple sites of inflammation that is going to occur. Now, that inflammation, which starts from the mucosa, spreads to submucosa, to the circular muscle, to the outer longitudinal muscle, and then to serosa. So, entire thickness of the bowel wall is involved. So, it's a transmural involvement. The problem kya hai? Once it's a transmural involvement, it is not limited at one particular site. It is involving at different multiple sites. And because transmural inflammation is occurring when two lumens which are inflamed, they come in contact with each other, there will be synechiae, and that synechiae is going to cause adherence, and that adherence will now result in internal fistulization. So there are multiple internal fistulas present, and all these inflammatory components, they are going to heal. Now, because they are chronic inflammation, they heal by fibrosis. Now, because of fibrosis, the lumen is going to become narrower. If the lumen is going to become narrower, what is going to happen? If the lumen gets narrower, what is going to happen? The stools which are going to present or the bowel content that is going to be present will not be able to move freely. Hence, it will present with intestinal obstruction also. It will result in stricturous presentation. Clear? आई बात समझ में? तो ये आपका बेसिक लॉजिक है with respect to your Crohn's disease. ठीक है? This is your basic logic behind Crohn's disease. Everybody clear with the Crohn's disease? ये इसकी disease की pathophysiology है. This is how it appears. Ulcerative colitis, on the other hand, is much more decent disease. So it starts with the inflammation of the mucosa. So it will result in inflammation of the mucosa, and it will remain as a continuous lesion. Now, because it remains in continuous lesion, you see the inflammation will occur, but it will always be limited to mucosa and submucosa. It will always be limited to the mucosa and the submucosa. It won't go beyond it. Now, because the wall is not getting involved, it will not result in stricture as you saw in your Crohn's disease. So, ulcerative colitis wale disease wale patient mein, in an ulcerative colitis, you will see only the mucosa is getting involved. Just for the sake of completion, if you look at this is the innermost layer is going to be mucosa. Okay. Then you have submucosa. Then you have the muscular layer. Then you have the muscular layer. Then you have the muscular layer, and the outermost is going to be serosa. The outermost is going to be okay. Now, so you have the mucosa, then you have the submucosa, the muscular and serosa. Here you see the disease is limited to mucosa and submucosa, right? Yeka, I get it. Sorry, I will take the class in English. On a popular demand, we thought I'll do it a little bit of Hindi, but okay, we'll do that, right? So as I was talking in terms of ulcerative colitis, in ulcerative colitis, the disease is limited to mucosa and submucosa, right? Unlike in Crohn's disease, where it is going to involve the entire thickness of the bowel wall, in the ulcerative colitis, the disease gets absolutely limited to mucosa and submucosa. It doesn't go beyond it. So hence, all the problems that you see in Crohn's disease, you will not see in ulcerative colitis. For example, in Crohn's, there are stricture. Stricture means narrowing of the bowel wall, and because of stricture, the stools cannot pass freely. Hence, there will be constant. There is obstructive features that you see in your Crohn's disease. Ulcerative colitis does not have that problem. Because the wall is not getting involved, there will be no strictures. The lumen will always remain patent. So what may come? Whatever, right? So the content will always flow. In fact, here the problem hasn't been always about diarrhea, but it is going to be never about obstruction. Now, because it's an inflammatory response, we all know inflammation is going to be associated with a lot of edema, right? So obviously it's an inflammatory response. There will be severe inflammation that is going to occur. And because it is not going outside the bowel wall, the inflammatory fluid that is going to get formed will remain inside the bowel wall. So there will be a lot of inflammatory fluid that is going to be accumulated inside the bowel wall. And because of this excessive fluid, obviously when there is more fluid inside, the more fluid will also eject out. So as I told you here, the patient's problem is going to be diarrhea. Here the patient will present to you with diarrhea rather than that of obstructive features, right? So here the content will have an easy passage. There is nobody who is going to restrict it. So in ulcerative colitis, we will not have problems like Crohn's disease. It is more about diarrhea. Is the concept clear? See? Vishnu is asking, but why there is more risk of colon cancer in ulcerative colitis than that of Crohn's disease? But again, that statement is not very accurate because currently the incidence of colon cancers are found equal with Crohn's as well as ulcerative colitis. But again, to be very precise, ulcerative colitis is slightly more in incidence of colon cancer when compared to Crohn's disease because all your active proliferating epithelial cells are always present in mucosal surface. And the one disease which is causing chronic irritation of mucosal surface is ulcerative colitis. In Crohn's, the entire wall is getting involved. Whereas here it is repeated involvement of your epithelial surface, and hence that is going to cause more irritation of the epithelial component where you have actively proliferating cells. Hence they can mutate on that ground, result in malignancy. Is that clear? Now, let's have a quick recap just to get a gist of what we were talking. The difference between the Crohn's disease and the ulcerative colitis. Don't worry, I've put up an entire table for you so that we can revise it. We can basically look at the differentiation, but I want you to understand this particular diagram. Now, if you understand this, your IBDs are sorted. You don't need to worry about IBD. If you understood every single complication that I'm going to talk about, every single problem that I'm going to talk about exists from these two diagrams. Okay? Now, if they have if the diagram is well understood, if they have gotten into your head, you will not forget even one single point. So let's have a quick recap. So you are going to tell me, right, what is the major difference between Crohn's disease and ulcerative colitis? This is Crohn's, this is ulcerative colitis. What is the major difference? Now I'm going to stand right in the center and you have to tell me. In Crohn's, there are going to be skip lesions. Ulcerative colitis, they're continuous. Crohn's, it is involvement of mucosa, submucosa, muscular muscles, muscular layer as well as serosa. It's a transmural involvement. Here it is only mucosa, submucosa. Now because it's an inflammatory disease, there will be edema. That edematous fluid is going to get accumulated inside the bowel wall. Hence it can also result in diarrhea. And outside, when the fluid gets accumulated, it is going to result in synechiae causing internal fistulas, and hence there will be bowel to bowel fistulas that are going to be found in Crohn's disease. Ulcerative colitis, on the other hand, it involves only mucosa, submucosa. The inflammatory fluid gets accumulated inside the bowel wall, and as the fluid increases, it results in diarrhea. Again, there's no stricture, there's no transmural involvement. The mucosa gets flattened out. You will know the reason why I'm telling about it. Now, out of these two conditions, when you look at very carefully, you will understand that Crohn's disease can present to you with diarrhea as well as constipation or obstruction. Why? Because when there is active inflammation, there is diarrhea. And when the inflammation subsides, it causes fibrosis. Fibrosis causes stricture. Stricture will result in obstruction. Right? So Crohn's is a disease which will go in hand. It will go tandem. Diarrhea, obstructive features of constipation. Diarrhea, obstruction features, constipation. Diarrhea, then constipatory features, obstruction, and they go in cycle. Ulcerative colitis, on the other hand, it says chill. It is going to present to you as diarrhea, and then obviously there will be colonic distension resulting in megacolon. That's it. Is the concept clear? Is the concept clear? Quick feedback. Is the concept clear? I don't know. Sometimes I feel I'm just shouting it for myself. Okay, got it. Right. So these are the differences between the Crohn's disease and the ulcerative colitis. Now let's take a comparative data. Now once you've understood this basic concept, then we'll basically ask you about all these important factors. Now, when you talk about the age of presentation for an inflammatory bowel disease, it's a bimodal age of presentation. There are two subsets, right? Now, the first age group that you will usually encounter, it is going to be around 20 to 30 years. And the second peak of the disease usually occurs in the fifth decade of life, that is around 50 to 60 years, right? So Crohn's disease, the initial age of presentation is at 20 to 30 years. The second peak comes at 50 to 60 years. The same validates for ulcerative colitis also. Initially, it is going to be 20 to 30 years, and peak, the peak is going to come between 50 to 60 years. The peak is going to hit between 50 to 60 years, right? Now, who is more likely to be affected in Crohn's as well as ulcerative colitis? Remember, Crohn's, it sounds like crown. Who wears a crown? Obviously, female. So hence, females are more likely to be affected in Crohn's when compared to males. Ulcerative colitis, right? So ulcerative colitis is, the word ulcer looks very aggressive. Who is more aggressive? Obviously, guys are more aggressive when compared to females. So here it is more likely to be affected in males when compared to females. Okay? So that's another differentiating point that you need to understand. Now, risk factors, when we talk about it, there's a small controversy behind it, but then I'll try to make it very simple. The usual risk factors that I can give it to Crohn's, it is going to be smoking, number one. Number two, it is seen secondary to intestinal tuberculosis. It is dietary component as well. So usually associate smoking, tuberculosis, and dietary component. Ulcerative colitis is purely an autoimmune disorder. So there are no specific risk factors for ulcerative colitis. There are no specific risk factors for ulcerative colitis. Is there anything protective for Crohn's disease? Nobody can save you from Crohn's. But then if you take a cigarette, light it up and smoke it, you might not get ulcerative colitis. So smoking is considered to be our protective factor for ulcerative colitis. In fact, if you're writing any of your competitive exams, this is one of the examiner's favorite question, probably because he also loves smoking. He wants to tell what are the benefits of having smoking. That is, it reduces the risk of ulcerative colitis. This class will continue for another 1 hour at least. Today we are doing a longer session. So my objective is to complete IBD beta. IBD khatam karne ke baad, we'll take a break today. Right? Now, let's talk about what are the genes which are associated. Now, this is also a very important exam question. The two important genes that you have to remember, it is NOD2 and CARD15. So two important genes, both of them are important from the exam perspective. There are no specific genes for ulcerative colitis. So NOD2, CARD15 are the two important genes that you should know for Crohn's disease. Ulcerative colitis does not have any predetermined genetic component. Now, what are the sites involved? Now, this is something which is very interesting in Crohn's disease. Remember, Crohn's, the entire bowel is involved. It is from the oral cavity. It is from the oral cavity to anal canal. It is from the oral cavity to the anal canal. it is going to involve. Now, from the exam perspective, sometimes they ask you what is the overall most common site. The overall most common site, it is going to be your terminal ileum. It is going to be your terminal ileum. Now, what is the least common site of involvement of Crohn's? In fact, earlier we used to say rectum is never involved, but now we say rectum can be involved. Rectal sparing is not a hallmark any longer for Crohn's disease. If you're looking for an update, remember rectum can be involved. Yes, the incidence of involvement of rectum in Crohn's disease is much more lower. So hence I can say the least common site of involvement of Crohn's disease, it is going to be rectum. It is going to be rectum. On the other hand, when you talk about ulcerative colitis, it is a disease of large intestine. It's a disease of large intestine. The most common site of involvement, it is going to be rectum. It is going to be rectum, right? If I say what is the least common site of involvement here, then it is going to be your anal canal. It's an anal canal. In fact, if there is a perianal disease, it goes more in hand with Crohn's disease when compared to ulcerative colitis. So these are the basic objectives that you need to understand with respect to involvement of the sites, right? Crohn's, anywhere between oral cavity to anal canal, but usually rectal sparing is noticed. That is why I say the rectum is the least common site, not entirely spared. Ulcerative colitis is a disease of large intestine. Rectum is the usual most common site of involvement, and the least common site of involvement, it is going to be about your anal canal. It is going to be about anal canal. Now we talk about the clinical features of, let it be an ulcerative colitis or a Crohn's disease. It's basically an inflammation of the bowel wall. Anywhere in the body, if there's inflammation, there'll be rubor, there'll be calor, there'll be dolor, there'll be tumor. The same features are going to be addressed here as well. So obviously any inflammation will result in obviously pain, and that pain in the bowel wall translates as abdominal pain. So these are the patients who are going to landed to the OPD or to the casualty with severe abdominal pain. In an acute episode, as I told you, there will be inflammation causing edema. That edema will result in diarrhea. Now, you know the diarrhea is because of inflammation. Inflammation causes, what does it cause? It results in friability of mucosa, and that mucosal erosions will occur. Inflammation causes mucosal erosion. Obviously, it becomes mucosa to become friable, and every time the bowel goes into peristalsis, it moves. It is going to become even more friable, and that friable mucosa, it is going to erode, it is going to bleed, and when it bleeds, it is now going to result in melena. And then later on, sometimes if it is rectal involvement, there will be hematochezia as well. There will be hematochezia. So usually it starts with abdominal pain, diarrhea, as well as melena, as well as hematochezia can be seen, right? On the other hand, because the overall most common site of involvement of the Crohn's disease is your terminal ileum, which is present in the right iliac fossa, it can present to you with, if there is involvement of terminal ileum. If there is involvement of terminal ileum, it can present to you with right iliac fossa pain with tenderness. Now, why I'm being very specific is, if you have a patient who has these features, the most common differential diagnosis that I can think about here is going to be acute appendicitis. The most common differential diagnosis that we can think about here is going to be acute appendicitis. It is going to be an acute appendicitis. Now, once the inflammation subsides, it is now going to result in fibrosis. Any chronic inflammation heals by fibrosis. So, because there is transmural involvement, there is a transmural inflammation. Now, that transmural inflammation will result in stricture. That will result in stricture. And that stricture later on will translate into obstruction. So Crohn's disease patient can also land up with obstruction, that we have already made it very clear in this representation. I told you how Crohn's can result in obstruction in comparison to that of ulcerative colitis. Okay? So this is what you basically see in your Crohn's disease. What will you see different in ulcerative colitis? Nothing as such per se. You will have the same features. Here patient will have abdominal pain. Patient will have abdominal pain. Along with abdominal pain, patient will also have diarrhea. They will also have diarrhea. Shedding of mucosa secondary to inflammatory response can also present to you with melena, sometimes followed with hematochezia as well. Sometimes followed with hematochezia as well. Right? So there'll be abdominal pain, there'll be diarrhea, there'll be melena, which can followed by your hematochezia. Now here, because there is rectal involvement is present, that rectal involvement can also result. Now, obviously, rectal shedding will cause bleeding, that is hematochezia. So rectal involvement will actually cause pain in the left side of the abdomen, which is more predominant, but then it is going to be of a more diffuse nature. Patient cannot appreciate in that particular region, right? Now, ulcerative colitis can also result with abdominal distension. Now that abdominal distension is because of involvement of the large ball. It is going to be involvement of the large ball. Okay? So same thing you have the abdominal pain, you have the patient with diarrhea, melena, as well as abdominal distension. That is why many a times, no, when a patient presents to you with these features, I might predict that patient is having an inflammatory bowel disease, but I will not be able to give you a confident diagnosis that it is ulcerative colitis or it is a Crohn's disease until unless I don't evaluate it. See? Now, because the patient had presented to you with features of IBD, that is abdominal pain, we have a standard objective that we'll do. The first thing, I will get an erect X-ray abdomen to see for any possible components. See? But more importantly, the X-ray findings are seen in a chronic phase or in a resolution phase where there already fibrosis are occurred. So once there is presence of bowel stricture, when there is a bowel stricture and you perform a contrast imaging, you can see the contrast will be able to flow through areas. Now, how do I depict this as? Now imagine that we're talking about this is the bowel wall. Let's say this is how the bowel wall is depicted, right? Now I'm saying the strictures here. There are strictures here. That strictures are present somewhere here. Few strictures are here. Few strictures are here. And few strictures are going to be here. Now when I give a contrast to this patient, that contrast tends to move along this line. It will only map the areas where the contrast can go. Right? So this is how it has been depicted across. So if you see, this is where the contrast is able to move. This is the thinning of the contrast. This is the thinning of the contrast that you have. This is the thinning of the contrast, and then it is going like this. So the areas where you have very thin passage and widening passage, right? So it looks like a bead here, a bead here, a bead here, a bead here, and there are strings which are attached, right? So this is what we call it as the string sign of Cantor. So this image that we have depicted, this is what we call it as the string sign of Cantor. And that's the first radiological finding that you would appreciate in a patient of Crohn's disease, right? You can see here beads here, 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 and so this is the contrast is flowing here. So this is what we call it as a string sign of Cantor. This is what we call it as the string signs of Cantor. Okay. That's the radiological finding that you will see in your Crohn's disease. On the other hand, when you look at the ulcerative colitis, in an ulcerative colitis, when you do an X-ray abdomen, now because the mucosa is going to get involved, repeated involvement of mucosa will cause mucosal fibrosis. There will be flattening of the mucosa. Now, if the mucosa becomes flattened out, usually in colon, usually in the large bowel, when you look at this, in a large bowel, you see you have these hostrations even in the mucosal surface, right? Now the mucosal hostrations, so let's say this is the bowel wall, this is the outer hostration. Now that band which are inserting, even the mucosa is getting inserted. Now repeated inflammation in this area will cause mucosal fibrosis. Now because of mucosal fibrosis, you will see that the outer hostrations will be maintained, but the mucosal flattening will occur. Because there is fibrosis in the mucosa, the mucosal hostrations are lost to this inflammatory response, which has now resulted in fibrotic elements, right? Now, this conversion of a hostration into mucosal flattening, it now see all these eventful hostrations are now become like a single pipe-like appearance, and this is what we call it as the lead pipe appearance. So you will see presence of a lead pipe appearance. You will see presence of lead pipe appearance. Okay. So it's a classical lead pipe appearance. This is a classical lead pipe appearance. The classical lead pipe appearance that you see across it. Okay. So these are the reasons why you have a string sign of Cantor, and then why do you have the lead pipe appearance on ulcerative colitis. When you look at intraoperative images, or like I can say you see in a specimens, the first thing you will see, because of skip involvement or skip lesions, it will form these patchy mucosal components, and this is what we call it as the cobblestone mucosa. This is what we call it as the cobblestone mucosa, right? Now, this cobblestone mucosa can also be interpreted, because when you see in a circumferential manner, it looks like a cobblestone, right? It appears as multiple stones have been put, like it looks like cobblestone is being put across it, right? So it looks like a cobblestone mucosa. It appears like a cobblestone mucosa. But when you lay open the bowel wall, you're looking like this. Now, if I open the bowel wall into a tract, okay, now the first image is a colonoscopic lumen. You're seeing like this, so you're seeing cobblestone mucosa. Now, if I open up the entire bowel wall, now it is becoming a flat like this. In the flattened out, after you cut the specimen out, when the bowel wall is becoming flat, when you look at it, it feels as if a bear has taken his claw and he scraped it, and this is what we call it as the bear claw sign. This is what you call it as the bear claw sign. Now you can see that this is the bear claw sign. As if a bear has taken his claw and pura scratched it, right? That's a bear claw sign. Now, when you look at the ulcerative colitis, one, you can see the mucosal erosions are present. Presence of mucosal erosion. And if you see very carefully, you will find these small nodules. Now, these small nodules that you are able to appreciate. these are what we call it as pseudo polyps. And pseudo polyps are the hallmark sign. They're not true polyps, they're just inflammatory polyps. They're the hallmark sign of what? Ulcerative colitis. Okay? So these are presence of pseudo polyps. Presence of pseudo polyps. Okay? So these are the various findings that you have. You have the cobblestone mucosa, bear claw sign in ulcerative colitis. There is mucosal erosions with pseudo polyps. There's a continuous lesions that you will see in the context of your ulcerative colitis. Another interesting thing about the Crohn's disease is this. Now the two images, one I'm saying showing it from the outside, another one I'm showing from the inside. Now what you can understand, then you take, this is the, let's say, the bowel wall that is present. And let's say this happens to be the outer layer of the bowel wall. I told you there's a transmural involvement, so it is going to involve the outer serosal layer also. So obviously we have an arrangement in the bowel wall, which is the mesenteric fat which is present. Whenever there's any erosion or any injury to the serosal surface, you will see the mesenteric fat that is present. So usually the mesenteric fat is going to be present from the mesenteric border. You will notice that the mesenteric fat that is present in the mesenteric border, once this injury is going to occur, once this injury occurs to the serosa, you will see this mesenteric fat that is aligned here. You will see this mesenteric fat that is being aligned here. You will see that slowly this mesenteric fat will creep. It will creep and then it will try to reinforce this area of injury, right? And this is what we call it as mesenteric fat creeping. This is what we call it as the mesenteric fat creeping. So mesenteric fat creeping basically tells you that there is a erosion that is present, that there is a erosion that is present in the mucosal surface or the serosal surface, basically on the bowel wall. To encounter that, there is a mesenteric fat creeping, which I showed you here. So this is an image of mesenteric fat creeping, which you can see here. So this is your mesenteric fat creeping. This is your mesenteric fat creeping, right? Another thing that you can see, obviously this whitish layer that you are able to see here, this whitish layer, it is nothing but stricture. So you can see involvement, transmural involvement. This indicates that in Crohn's disease, there is a transmural stricture. That is, the entire thickness of the bowel wall is involved. The entire thickness of the bowel wall is involved, and this is your transmural involvement resulting in transmural stricture. It is resulting in transmural stricture. Clear? Everybody clear with this? So far, koi sawal, koi shak, any questions, any doubt? Chalo. Now in the same context, to understand the severity of the inflammatory bowel disease, it's for both Crohn's as well as ulcerative colitis. So to understand the disease severity, in both Crohn's disease as well as ulcerative colitis, we take diarrhea as the measure of severity, obviously, because one of the predominant features that you will have in an ulcerative colitis or Crohn's disease will be diarrhea. Now, based upon the episodes, we divide them into a mild disease, into a moderate disease. There's a mild disease, there's a moderate disease, there is severe disease, and there is fulminant disease. There's a fulminant disease. right? Now, what is the criteria to call whether the patient is having a mild, moderate, severe, or fulminant, right? To call a patient is having a mild disease, remember it should be less than 4 episodes of stools per day. It should be less than 4 episodes of stools per day. Moderate में क्या है? If it is more than 4 episode of loose stools, basically you're talking about per day. Severe is going to be more than or equal to 6 episode of stools which are going to happen per day with presence of blood in stools. With presence of blood in stools. Fulminant का definition is important. If more than or equal to 10 stools per day in association with toxic megacolon. Now, radiologically, to say the patient is developing a toxic megacolon, we say the widest diameter of the transverse colon, right? So, I'm going to measure the widest diameter of transverse colon. Now, if that diameter is more than 6 centimeters, then I say patient is having toxic megacolon. So on an X-ray, you will see the distension in the transverse colon. If that distension measures out to be more than 6 centimeters, then of course it will be called as toxic megacolon. Polaris, I've taken your point. Once the GIT is done, we will see. Okay. Once we are done with the GIT, in fact, GIT, we are almost nearing the end. ठीक है? एक कॉलोनी था, I don't know, sir, batch lecture and Sankalp. Guys, I'm not able to get your chats. I think somebody deleted that chat also. ठीक है, fine. But see, when you look at our Medit के app पे जो हमारा lecture है, those lectures on the Medit app are purely for NEET PG and INICET. So obviously you will not find it this much detailed, where I'm trying to tell you every single component of it. So these are more detailed lectures. This is basically targeted to all the students who are in final year, who are preparing to read for final year, and all my residents who have recently joined general surgery, so that they get grip of the subject. तो ये BLS series का objective ही है कि this is like this. See, if you want to read better, no, if you want to know all the nitty-gritties in order to crack the exam, IBD which I'm teaching you right now, it is going to be for 2 hours lecture. IBD we have done in our NEET PG lecture or INICET lecture हमारे app में है for around 45 minutes to 1 hour, right? So I'm going to give you all the important crisp content which is important from exam perspective. Now there you will see it in a much different way. The approach is different, the comparison is different, the way you remember is different, the exam orientation will be different. So I would have incorporated all that. Here I am not bound with time. I am only bound in a way that I can explain you in the best possible way. So BLS series is more extensive. It is going to take care of every single component that exists in a topic. I'm not filtering it out कि ये exam के लिए important है, this is important, this is not important. No. In BLS, we teach whatever that exists in a textbook, whatever you're supposed to read. In fact, if you go back and see the Bailey also, no, there's certain things which I've taught you in BLS series which does not exist in Bailey also. I've taken it from Sabiston, I've taken from Shackelford's, I've taken few topics from Blumgard's, I've taken, if you go back to my breast cancer, you'll see a little bit of protocol that I've taken from Devita, MD Anderson textbook of surgery. So there are a lot of textbooks which I've compiled, and BLS, my goal is to make it as a gold standard for surgery's resource. So that's the objective and goal that we have kept. So hence we are working in those contexts. ठीक है? Clear? All right. So can we move on? Quick feedback. और कोई सवाल? बेटा prof exams के लिए ideal is going to be BLS. I share my notes, I give you everything, I give you in a structured format. तो prof के exam को crack करने के लिए BLS is your go-to series. ठीक है? There is no if, there is no but. ठीक है? चलो. Right. So as we are talking about disease severity, एक additional paper add कर लेते हैं यहाँ पे. So we'll talk about the severity indexes and their complexes. So scoring system for ulcerative colitis. We're talking about the scoring system for the assessment of ulcerative colitis. It is your ulcerative colitis assessment, right? Now, what all do we incorporate? What all do we incorporate in this scoring systems? Okay? So the parameters that we will consider, number one is the frequency of stools. Number one is the frequency of stools. Based upon that, I will be giving a particular score that we have, right? Then you have rectal bleeding. So we'll try to incorporate each individual one so that we do the scoring well. The first prospect, it is going to be the frequency of stools. Now, based upon that, if the frequency of stools is normal, a score of 0 is given. If it is 1 or 2 more than normal, let's say patient used to have 1 bowel movement per day, or let's say 2 bowel movements per day, then it is going to be considered normal. But if you overbound that, if the episodes of stools are going to be 1 or 2 more than its usual one, a score of 1 is given. If patient has 3 or 4 more than normal, a score of 2. It is 5 plus than normal, then a score of 3 is given. Right? So that's the frequency and the scoring that you have. The second component in the scoring is about the rectal bleeding. It is going to be the rectal bleed, and then you have a score. We call it as a sub score rather than saying the total score. This will be called as a sub score. So here also we look at the sub score. Right. Now look at the rectal bleeds. If there is none, there is no rectal bleed, a score of 0 is given. Streaks of blood. If there is streaks of blood, right? But less than 50% of the time. Less than 50% of the time, that means every time the patient passes through, score of 1. If it is more than 50% of the time, a score of 2 is given. If only blood alone is passed, a score of 3. If blood alone is passed, a score of 3 is given. Right? Now, based upon the sigmoidoscope, so the third component that you would do a sigmoidoscopy. So based upon sigmoidoscope, based upon the sigmoidoscope, what are the findings that you have, right? So we will measure the disease activity. We will look for the disease activity on a sigmoidoscope, and based upon that, I would basically give a score here as well, right? Now, on a sigmoidoscope, if it is normal looking mucosa, score of 0. If there is a mildly inflamed mucosa, score of 1. If there is a moderate inflamed mucosa, score of 2. If there is severe inflamed mucosa, a score of 3 is given, right? Then you have the global assessment about its general well-being. So when you look at the global assessment, in the global assessment, again, you look for a subscore. In the global assessment, we'll see if the patient is normal, if there is mild disturbance in activity, if there is a moderate disturbance, and if there is a severe disturbance of a score of 0, 1, 2, and 3 is given, right? So these are all the scoring components that you're going to assess or going to evaluate for ulcerative colitis, for your ulcerative colitis, right? Again, rather than trying to remember the entire scoring system, especially for the exam perspective, remember what are the components. Number 1 is the frequency of stool. Number 2 is rectal bleed. Number 3 is the sigmoidoscopic finding, and the global assessment of a general well-being are the 4 components that you will look for your ulcerative colitis. Same way you can do for Crohn's disease also. But Crohn's disease, we have a named staging that we are going to follow. That is called as the Montreal classification for Crohn's disease. We have the Montreal classification for the Crohn's disease. Talk about the Montreal classification for your Crohn's disease, right? Now, we look at the whole scoring pattern. Now, number 1 is the age of diagnosis or age at diagnosis. Age at diagnosis, you have subcategories as A1, A2, and A3. Age of diagnosis is age less than or equal to 16 years. A2 is between 70 to 40 years. And A3 is age above 40 years. Age above 40 years, right? So that's the first component that you have. Next is going to be progression. Next factor is the progression of the disease, right? In the progression, we have B1, B2, and B3. In B1, there is only inflammation. In B1, there is only inflammation. B2, there is stenosis. There is stenosis of the bowel wall. B3, there will be presence of fistulas that are going to be formed, and obviously serosal erosions which are present, so it is called as penetration. There is presence of penetration, right? Then the last one is based upon the location. Location, we have L1, L2, L3, and the L4 disease. L1, it is going to be ileal, which is the most common site. L2 is going to be colonic. L3 is going to be ileocolonic. It is going to be ileocolonic. And L4 is going to be an upper GI tract. It is your upper GI tract. It is going to be your upper GI tract, right? So this is the Montreal classification of the Crohn's disease. It's the Montreal classification of a Crohn's disease based upon the age at which diagnosis is done, progression of the disease, in what component it is, and the site of the disease based upon the location. Right? So there are two factors that you have for ulcerative colitis, as well as for your Crohn's disease. Correct? Sure. So that was with respect to the components here. Okay. So this is about the presentation of both the inflammatory bowel diseases, that is going to be your ulcerative colitis as well as Crohn's disease. So for any questions, quick feedback. Great. Chalo. So we'll do one thing, we'll take a 5 minutes break here and then we'll continue for the day, because the next part will be your extra intestinal manifestation diagnosis. We have already done with the components here, and then the management protocols. Okay? Chalo. Take a 5 minutes break, we'll resume back. So it is 7:10, we'll resume back at 7:15. We're just going to leave it here. We'll resume at 7:15. When will you begin the urology section? Soon after we are done with GIT. After GIT, we'll start with another system. I mean, GIT is there, hepatobiliary pancreas is there, then you have urology. Okay? Chalo. All right, guys, let's continue. Right, so we'll be talking about the extra intestinal manifestation. तो एक पेज ऐड कर लेते हैं. Talk about the extra intestinal manifestation of IBD. It's an extra intestinal manifestation of inflammatory bowel disease. So talk about the external manifestation of IBD. We'll take a comparative component between the ulcerative colitis and the Crohn's disease. Okay? So talk about the extra GI manifestations of IBD. We'll be comparing ulcerative colitis in response to Crohn's disease. The most common system overall to be involved in an extra GI manifestation, it is your musculoskeletal. The musculoskeletal system is the overall most commonly involved when it comes down to extra GI manifestations. When it comes down to extra GI manifestations across here, right? Now, when you talk about what are the musculoskeletal components that you have in ulcerative colitis, it is your peripheral arthritis. It is the peripheral arthritis, right? It is also associated with axial arthritis, right? Sacroiliitis kind, and then also osteoporosis. So it is peripheral arthritis, axial arthritis, and osteoporosis are the musculoskeletal components that you will be seeing in ulcerative colitis, right? On the other hand, when you have in Crohn's disease, the same set that you will see. So here you will see presence of peripheral arthritis. There will be presence of peripheral arthritis. It will also be associated with axial arthritis. There is peripheral arthritis, there is axial arthritis, there is independent sacroiliitis, and also there will be osteoporosis. But if you see overall, which is, see, most common extra GI manifestation overall is going to be musculoskeletal. In musculoskeletal, the most common in ulcerative colitis is peripheral arthritis, and the most common in Crohn's disease is also going to be a peripheral arthritis, right? So these are the two important components of your musculoskeletal objective. So that's between ulcerative colitis as well as Crohn's disease. That's your musculoskeletal. Now, apart from that, the next one that you have is your skin condition, that is dermatological. So, talk about dermatological in ulcerative colitis. It is associated with erythema nodosum. It is associated with erythema nodosum, pyoderma gangrenosum, pyoderma gangrenosum, erythema nodosum, pyoderma gangrenosum, and rarely it is associated with psoriasis. So, erythema nodosum, pyoderma gangrenosum, and psoriasis are the skin manifestations that you see with respect to ulcerative colitis. In the Crohn's disease, you'll have the same findings. You will have erythema nodosum. You'll also have pyoderma gangrenosum, but they usually do not have psoriasis, right? They have skip lesions of the skin. We call it as the skin skip lesions. In association, they have skin skip lesions that you can see. That is your dermatological. So, the skin manifestations that you have. Then you have the ocular manifestation. That is for the eye. Now, in an ocular manifestation that you have, number one is episcleritis. Number one is your episcleritis. Then you have uveitis and scleritis. Episcleritis, uveitis and scleritis. The same thing will also be seen in your Crohn's disease also. The same manifestations will be seen in Crohn's disease as well. Then you have hepatobiliary. Now, in a hepatobiliary, number one is primary sclerosing cholangitis. Now, primary sclerosing cholangitis, it is one of the strongly associated with ulcerative colitis. Here, it is associated with gallstones and fatty liver. So, I can see the fatty liver is seen here also. But from the exam perspective, primary sclerosing cholangitis is associated with ulcerative colitis. It is associated with ulcerative colitis, right? Now, these are the extra GI manifestations that you should be aware of, right? Now, I know you're thinking, sir, there's so much of extra GI manifestations. What do we remember? How do you remember it? Because you are my students and I can't let you go disappointed. So, for that, to have a quick component, by the order of incidence, right? So, you talk about in terms of inflammatory bowel disease. In an IBD, from most common to least common. From most common to least common. The first one is arthropathy, that is joint problems. Number two is skin lesion. Number three, it is ocular lesion. It is your ocular lesion. Number four is hepatobiliary. It is your hepatobiliary. Then you have thromboembolic complication. Thromboembolic complications. Example like DVTs and all. Then you have renal. In the renal manifestations, we are talking about stones. And then you have pulmonary manifestations, which are rare. So renal as well as the pulmonary component, they're not very common, they're usually rare. So we talk about, in pulmonary component, we're talking about bronchiectasis and interstitial lung disease. And the interstitial lung disease. It's an interstitial lung disease, right? Here we're talking about stones, amyloidosis, and all that. So these are your extra GI manifestations that you should be aware of. Now, how do we remember them? I know it is quite difficult, but then you need to understand that all these are seen in human beings also. So this is the head, this happens to be the neck, this happens to be the trunk. These are the lower limbs. This happens to be the upper limb. So all the extra GI manifestations, you can see it from here only, right? So when you look at this, we're talking about this is right. So the first and the foremost that you see here is going to be your arthropathy, that is joints. The second that you will see is going to be his skin lesions. Third, it is going to be his ocular lesions. Fourth, it is going to be hepatobiliary. Five, it is going to be thromboembolic events, that is DVT. Six, it is going to be renal components. Because kidney looks like six, it has renal components. And the last one, that is your pulmonary component. Okay. So these are all your extra GI manifestations. The first is arthritis, second is skin lesion, third is ocular manifestation, then you have hepatobiliary manifestations, thromboembolic events, renal components, as well as pulmonary components. You remember this guy? This guy is the number one guy. Okay. You remember this? You will know all these components. But you're still not there yet where you can crack a competitive exam. So the questions in competitive exams, how do they ask you? आपसे एग्जाम में सवाल कैसा पूछा जाएगा एंड दीज आर योर क्यू पॉइंट्स सो anybody who's preparing for a NEET PG or an INICET or any other competitive exam, these are the pointers that you're supposed to remember, right? Now, if I ask the question, what is the most common extra intestinal manifestation overall in ulcerative colitis? The answer is peripheral arthritis. It is going to be peripheral arthritis. I change the question. What is the most specific? Which is the most specific extra-intestinal manifestation in ulcerative colitis? The answer is primary sclerosing cholangitis. It is your primary sclerosing cholangitis. Skip lesion का मतलब होता है इधर उधर होना. It is not. Skip means they present here and there. They are not in continuity. You will not see them in continuity. Right? Now, another important question is extra-intestinal manifestation paralleling the disease activity. Paralleling disease activity, that is along with the disease. The answer is going to be peripheral arthritis. So if you look at the order, number one is peripheral arthritis. Then you have episcleritis. And if not, then you have erythema nodosum. Then you have erythema nodosum, right? Question, if I change extra-intestinal manifestation independent of disease activity. Independent of disease activity. Independent of disease activity. The answer is primary sclerosing cholangitis. Primary sclerosing cholangitis. Ankylosing spondylitis. Ankylosing spondylitis. Uveitis. And pyoderma gangrenosum. It is your pyoderma gangrenosum. Okay? So these are your previous exam questions, right? Now, continuing, if I have to make you more tricky, what is the most common extra-intestinal manifestation in Crohn's disease? In Crohn's disease, the answer remains the same. It is your peripheral arthritis, right? If I change the question to most specific, which is the most specific extra-intestinal manifestation in Crohn's disease? The most specific, it is going to be nephrolithiasis and cholelithiasis. Nephrolithiasis and cholelithiasis. Or in simple words, gallstones. It's going to be gallstones. Clear? So this is what your carry home message is going to be for your inflammatory bowel disease. Clear? So we covered your extra intestinal manifestations also, right? Now, so you have done the investigation, you have looked at the colonoscopic findings, and now you know the patient is having either a Crohn's disease or an ulcerative colitis. Now, many a times we have a confusion that what should be the approach for the management. So we'll take it in that particular sense only. Okay? So talk about the management. I'll compare with Crohn's as well as ulcerative colitis. So we'll start with the management of Crohn's disease. So how would you like to manage a patient of Crohn's disease? Now, I'll give you an algorithmical objective that how do you want to manage a patient of Crohn's disease? See, in Crohn's disease, because there's inflammation, you have to subside the inflammation. If there's stricture, you have to do a stricturoplasty. But because the disease is so extensive that I cannot do an extensive surgery, otherwise I have to remove the entire bowel, which is technically not possible. So what are the protocols that we follow? Now, the currently protocol that we follow is, if a patient initially presents to you with mild Crohn's disease, I've already told you mild, moderate, severe, and fulminant. On that basis, if there's a mild Crohn's disease, mild and then it is localized, if it is localized to ileocecal, if it is localized to ileocecal, I will start the patient on steroids. Now, the steroids that we prefer right now is budesonide. The steroid that preferred is going to be budesonide, right? Or you can start with steroids. This is going to be only the initial phase that you have. Then the maintenance that you have, this is to start the patient on steroids, and then the maintenance is going to be with 5-amino salicylic acid. Okay? So 5-ASA is going to be for the maintenance for mild form of Crohn's disease. But if a patient develops moderate to severe, if patient develops moderate to severe form, if there's a moderate to severe form of Crohn's disease, start the patient on systemic steroids. You start the patient on systemic steroids, and this is your induction phase. And then take the patient to immunomodulators, that is for maintenance. For maintenance, we usually switch it to immunomodulators. You usually switch it to immunomodulators, right? Now, immunomodulators can be your azithromycin. You have the other components which are available. For in general, as we say, immunomodulators has to be put across, right? Now, Along with immunomodulators, you also have the biological agents that you have. In the biological agents, that one I would like to perform is your anti-TNF factor. Then you have vedolizumab. All these can be taken into consideration, right? Surgery in Crohn's disease is always a last resort. We do not prefer it. So mild to moderate, mild mein you start that is binosteroid, put it on maintenance of 5-ASA. Moderate to severe, you do a systemic steroids for induction, then put the maintenance on immunomodulators or biological agents. If the patient develops stricture, you do stricturoplasty. If patient presents to you with perforation in Crohn's disease, then you have only a limited excision. Now, when I say limited excision, what do you mean by this? Limited excision's concept is very important. So let's say this is the bowel which is having Crohn's disease. This is a loop of the bowel that you have. And you see there's a lot of diseased part that you can see here. There's a diseased part here. There's a diseased part here. There's a diseased part here. But perforation has occurred only at this particular site, right? The other sites of the bowel are fine. Normally, when you go in and you see the diseased part, you try to excise the entire segment and then anastomose it. In Crohn's, we are not going to do this. In Crohn's, I'm only going to excise the part where the perforation has occurred, right? Only this much part is going to be excised. Only this much part of the bowel will be excised and rest will be anastomosed. This is what we call it as limited excision, not trying to eradicate the entire disease because the entire bowel itself is diseased. So it's going to be very difficult for us to eradicate the disease. It is going to be very difficult for us to eradicate the disease. Clear? Now, these are the things that we've been talking about in terms of Crohn's disease, which is going to be very, very important. Ulcerative colitis, on the other hand, they're slightly different because ulcerative colitis is curable. Crohn's is only manageable. When you come down for ulcerative colitis, we talk about the management of ulcerative colitis. We look at the management of the ulcerative colitis. Right. The ulcerative colitis, again, it depends upon the presentation is mild, moderate, severe, or is it fulminant, not fulminant. In those contexts, we look at the management of the entire this thing. Now, for ulcerative colitis, the managements are very important in terms of their presenting components. The first one is also the first line of ulcerative colitis is also going to be a medical management. This is also going to be a medical management, but I don't want you to confuse because when you talk about medical management, my goals are very precise, right? Now, what is the goal of a medical management that you're looking at, right? Number one, whenever you start a medical management, you should make sure the disease severity should come down. So there should be remission of active disease. There should be remission of active disease. That's my first goal. Along with that, long-term disease free. Long-term disease free period. Long-term disease free period, right? Prevent complications and surgery. Prevent complication and surgery. And the last one is just to improve the quality of life. Improve the quality of life. They're the four important, I would say, the goals that we have. The first goal that you can see, it has to remission of the disease, long-term disease-free period, prevent any complication and possible surgery, and then last, improve the quality of life, right? Now, in the medical management, what are the components which are available? Now, in the initial, what you call it as the induction therapy phase, you have the 5 ASA molecule, that is amino salicylates. In the amino salicylates, you have sulfasalazine, which is preferred. So you have the drugs like sulfasalazine, mesalamine, sulfasalazine, and mesalamine, right? Apart from that, you can give corticosteroids. You can give corticosteroids, prednisolone, budesonide. All these are acceptable steroids that you have. And then prophylactic antibiotics. Prophylactic antibiotics, right? Now, this is a first line medical management. Now, along with the medical management, in the maintenance therapy, you can use immunomodulators. In the maintenance therapy, I can use immunomodulators. I can use immunomodulators. The immunomodulators that I can use is azathioprine. I can use azathioprine, 6-mercaptopurine, 6-mercaptopurine, and methotrexate. Right? Then you have the biological agents. Now, in the biological agents, number one is your anti-TNF agents. Now, in the anti-TNF agent, you have infliximab. We have infliximab, adalimumab, right? These are anti-TNF agents. You can give anti-integrin. Your anti-integrins are vedolizumab. You can give anti-interleukin 2 and interleukin 3. Anti-interleukin, 12 and interleukin 13, right? This is ustekinumab. That is ustekinumab. These are monoclonal antibodies, right? So all these are your biological agents that we have, right? The other drugs that your pharmacologist will tell you in great detail, it is going to be the small molecule drugs, example like JAK inhibitors. JAK inhibitors are, I think, tofacitinib, which is approved. Tofacitinib is your JAK inhibitors. Then you have another one is, I think it is S1P modulator. This is going to be ozanimod. It's a ozanimod. Okay. All these are in the maintenance therapy, right? Now, if the patient fails the medical management, then goes the surgical management. If there is failure of medical management, if there is failure of medical management, it will lead to surgery. Now, in the surgery, what are you going to do? The surgery that we perform for ulcerative colitis. See, the surgery in ulcerative colitis is done with a curative intent, not with a palliative intent, right? So, what surgery do you do? You do total proctal colectomy with ileoanal J pouch anastomosis. With ileoanal J pouch anastomosis. So we create a J pouch to create a reservoir. Now, what do you mean by this, right? Now, when we look at the whole concept of this, let's say this happens to be the esophagus, this happens to be stomach, this happens to be duodenum, this happens to be the jejunum, then you have the ileum, terminal ileum, appendix, cecum, right? From here, you see that you have the ascending colon, the transverse colon, the descending colon, all the way to your rectosigmoid, and then at the end you have the anal canal, right? This is what we have, right? Now when I say total proctal colectomy, right, that is from the rectum all the way to the terminal ileum. So this is the marking points. I'm going to take it all the way from the rectum to the terminal ileum, right? This whole part I'm going to remove. So I'm just going to shade what I'm going to remove. I'm going to remove the entire ascending colon, cecum, appendix, terminal ileum, transverse colon, descending colon, rectosigmoid. Until the rectum, it is removed. Once you remove this, what are you left out with? You are left out with the esophagus, the stomach, the duodenum, the jejunum, and the ileum is left here, right? And obviously, this is your anal canal that is left behind. Okay? So only left behind with these two. Now, if I go and directly anastomose this, all the content which is going to flow from the small bowel will go into the anal canal. And because it is in a liquid format, this succus centricus is going to be in a very liquid form. So obviously there's no reservoir. All that stools are going to go into the anal canal, and patient has to defecate multiple times, right? Here the episode of stools per day can be as high as 15, 16, 20 times. That means you're looking at, if you have 15 episodes of stool or 20 episodes of stool, every hour you have to go to washroom. It becomes very cumbersome, right? So patient says it's quite difficult, doc, help me, because if you allow the stools to pass through, then there is no stopping back. So we have to create a reservoir, right? How do you create a reservoir? I now create a reservoir by turning the ileum into its own loop, right? So I've taken this entire segment of the bowel loop. I've taken the entire segment of the bowel loop. I have turned this in this particular fashion. ठीक है? इसको ऐसे J pouch की तरह घुमाया. We have rotated it, right? Like a J pouch. This is where the anal canal is present. This is the anal canal, right? So what I did is I sutured this end. Okay? This end of the ileum is sutured. I made an opening on this side and I made an opening on this side. So both the ends on the sideways is open, and after they're opened, I have sutured this. Now once I've sutured, they become as one cavity, right? They become as one uniform component. I have opened at this point again bottom. Now once I've opened, now I am going to anastomose with the anal canal. I will anastomose with anal canal. So this is total proctal colectomy with ileoanal J pouch anastomosis. Okay? So that's your J pouch. This is your anal canal. This happens to be your ileum. This is your entire colon. So if you look at the entire diagrammatic representation, total proctal colectomy with ileoanal J pouch anastomosis. And that's the surgery of choice for your ulcerative colitis. Is that clear? Is that clear? Somebody saying AI is going to take doctor's job in 10 years. Uh, First of all, no matter what happens, see, AI will become a very good tool for you in order to process, diagnose, and curate a good treatment plan for your patient, but it will never treat the patient per se. That's the first thing. Second, I would not say that AI will eat the doctor's job, but those doctors who do not know how to use AI may find it difficult when compared to the people who know how to use AI, right? So everything that is change, see, the one thing that is constant in this world and life is change. You need to change with the changing time so that the change does not affect you. That's the most important carry home message. Change is eternal, change is constant, it will continue to happen. You evolve by changing, you don't evolve by staying where you are, right? So that's what you need to remember with respect to your future prospect. So that's all for your inflammatory bowel disease. So today I've completed the entire IBD. It was a 2 hours lecture, but we tried to make it a complete crisp one so that you don't need to worry across. So all those people who thought कि कल BLS नहीं हुआ था और यार class miss हो गया, we have completed the entire session. Go have a look at it again and make sure you read it as well. Thank you so much for joining. Until then, goodbye, take care, bye bye.